Hello everyone, welcome to this open hand webinar. My name is Nicola and I will be your host for this evening. So tonight we are going to be taking a look at managing the hand abscess. We have two exciting presentations lined up for you, followed by time for questions. So our first presenter for this evening is Adri. She graduated with her Bachelor of OT degree from the University of Victoria in 2004. Adri has spent most of her 20-year career as an occupational therapist working at Manguzi Hospital, located in a beautiful rural area in northern KwaZulu-Natal. Although Adri works in a generalist capacity, as is typically the case in rural settings, she has a special interest in hand therapy and completed her postgraduate diploma in hand therapy at the University of Victoria. She established a specialist hand clinic at her hospital in 2016. Adri was honored for her work in rural practice in 2021 when she received Rural Rehabilitation Healthcare Worker Award. So Adri is going to be covering initial management of the hand abscess and how to prevent stiffness. Thank you, Adri.
Thank you, Nicola. Thank you, and good evening, everyone. For this presentation, I am going to share my screen, and I'm also going to turn off my video as I'm not too sure if my connection will allow all the things. All right. Tonight I'll be chatting to you about hand sepsis, a hot, sticky mess, and how to handle it. So Manguzi is a district hospital located in northern Zululand in KwaZulu-Natal with a subtropical climate. Septic hands, septic fingers, and septic feet are common admissions at Manguzi Hospital. A small penetrating wound can quickly develop into an abscess, which becomes a hot, sticky mess if left untreated or treatment is delayed. It is considered a surgical emergency when a patient presents with a hand abscess. Recurring sepsis, stubborn edema, pain, and loss of range of motion resulting in stiffness are secondary complications. Today, I will discuss briefly the assessment and treatment modalities to treat this common and problematic condition using some case studies, as well as starting off with wound management. Warning, the next few slides have pictures of wounds and there will be blood. I don't think we can start looking at hand sepsis without dealing with wounds and wound care. So I'm sure you've all seen quite a bit of wounds in your time. In the hospital where I work, septic hand wound care has become synonymous with occupational therapy. This has taken me some time to establish, but wound care is a vital part of the functional outcome and decreased hospital stay for many hand pathologies. In-servicing with doctors and especially nurses on the surgical wards can help you to establish early referrals. Get involved in your ward rounds and assist nurses with wound care and how to dress the hands. All septic hands and fingers are referred to OT early. Usually, a patient that presents with a septic hand will be admitted to the surgical ward via the operating theatre. Sepsis is managed by surgical incision and drainage, usually a collection of pus, debridement to remove the foci as well as any dead skin or tissue that may lead to further sepsis, antibiotics, daily dressings, and therapy. At our hospital, the OT department manages most of the septic hand and hand wounds, and we follow the following procedures or steps. We have moved away from hand baths and clean septic wounds by washing wounds with boiled water that has been cooled down or sterile water that has been warmed up. The reason for having lukewarm water is to maintain stasis in the wound, as cold water damages the macrophages. We use Hibi scrub or pink soap that is found in most government hospitals to wash the wound as well as the surrounding skin. Wash the wound as far as possible under running water and avoid dunking a septic hand into a wound bath. Visible slough is removed with sterile gauze and sterile tweezers. This is done either in the OT department or at the patient bedside. We use sterile dressing packs as far as possible. Daily wound washouts are indicated in heavily exudating wounds or deep infections. Special dressings that can assist with managing exudates and thus the moisture balance are products that are available on the national tender. An absorbent fiber and non-stick foam dressing work well. be sure to have a moisture layer between the fiber and the wound. If the foci of the sepsis has been removed, we respect the healing timeframes and allow for 2 to 3 days between wound dressings. If the foci has not been removed or the infection is deep, the patient may need to return to theatre for further I&D. This may happen when you are working in a district hospital where the general surgeon does not feel comfortable doing a thorough debridement on a hand. When you are doing your dressing checks and the dressing is soaked through, this is an indication that the dressing needs to be changed, and the wound probably needs a wash. If you find that the exudate is pus, it is essential that you advocate for the patient to return to theatre. We are familiar with the phases of healing, but I would like to discuss wounds by looking at the wound more closely. It's important to remember that phases of healing is not step by step. This is a compendium, so you might spend a little bit more time in either of these phases. I would like to introduce you to the acronym of TIME to look at the principles of healing of a wound and what we would like to see and not see when we are moving through the phases of wound healing. So the T stands for tissue. What do we see? Is it bone? Is it tendon? Is it muscle? Is the tissue black or necrotic? Then it means we need to hydrate or debride. If the tissue is yellow, it's probably slough or or pus. And then debridement is also indicated either chemically or surgically. And then if you see pink tissue or red tissue, that is usually healthy tissue and means that you're on the right path. Your wound is healing. Moist wounds heal 4 times faster than dry wounds, and that is why finding the right moisture balance is vital. Infection or inflammation. If you see any of the following signs, red, swollen, smell, or heat, then you know that the infection is still present. You can see in the picture how red the lady's hand is. If there are maggots present in your wound, which some of us might have seen, you can use a 10% peroxide solution to wash out the wound and then use twice as much sterile water or saline afterwards. It is important that a wound swab is taken if you have consistent or continuous inflammation and sent for an MCS. This will determine what bacteria is causing the infection and what antibiotics the patient needs to be on. It also shows you what the bug is resistant to. It's very important to remove the infected foci to prevent prolonged infection or staying in the inflammatory phase. With a high bioload or prolonged inflammation, there is an increase in inflammatory protease or cytokines and a decrease in the growth factor, causing delayed wound healing. If we look at the M, it stands for margins. If it is white, it's macerated, it's too wet. If it's brown or crusty, it's too dry. And if it's pink and clean, it's like Goldilocks, just right. It's the excellent moisture balance. Macerated wound edges can mean that your wound is too wet. When you are using a hydrocolloid dressing, it's a dressing that draws exudate away from the wound bed and collects it on the top. This can often cause the wound edges to become macerated, but it does promote tissue granulation. The macerated tissue around the wound can be debrided using a sterile blade and tweezers. And remember, this skin is already dead and it will not cause any pain if you cut it away or pull it away from the wound. The last one we look at is the exudate. What is draining? How much is draining? How does it smell? If it's greenish, it's probably Pseudomonas. If it's yellow, it's probably pus. And if it's red, it's hopefully blood. If the wound is Pseudomonas or has Pseudomonas in it, you wash it out under running water and you can clean it with an acetic acid solution. To ensure a sterile wound bed and surrounding skin, it is important to wash the wound well. Use sterile water or water that has been boiled and cooled down. You can add Milton solution to the water at 1 ml per 10 milliliters. So in 1 liter, you will put 100 ml of Milton, and that will sterilize your water quite nicely. Now I would like to look. Hold on. if we're looking at hand sepsis, I'd like to introduce you to Mr. BM. Mr. BM presented at the Hands Outreach Clinic a few years ago. He was not booked and arrived at the OPD the day before and was told to come back to the hand clinic the next day. His hand was held in a sling made from a scarf around his neck, and he was visibly in pain. When he removed his hand from the sling, it was swollen and shiny. He was unable to move his wrist or fingers. He was referred to OPD to be admitted via theatre for an immediate incision and draining, I&D. A soft tissue biopsy was ordered and sent to the lab for microscopic culture and sensitivity, MCNS, and to investigate for possible TB. An X-ray was also ordered to establish if there was osteomyelitis. A hypothenar incision was made and a pus collection was found in the hypothenar fascial space and drained. A corrugated drain was inserted and left in the wound to allow for further draining of the exudate. The patient was sent to the ward and started on double antibiotics. The patient was reviewed day 2 post-I&D in the ward and required further I&D as the wound still had heavy pus exudate and the edema and warmth had not subsided. The edema was putting the patient at risk for compartment syndrome, and he required surgical intervention to release the pressure. The patient was discussed with me, and I attended theatre to make an intrinsic plus splint to maintain his hand in a safe position and assess what possible ROM was available. The assessments done, we looked at his edema, his range of movement, and his wound healing. He was admitted for 13 days, and during those 13 days, he received 10 occupational therapy sessions. The edema was measured using the circumferential measurement technique. As I do not have a volumeter, I used the percentage method to assess the improvement in the edema in the first 4 days of wound healing. The percentage is calculated by taking the circumferential measurements, in this case at the wrist joint, 4 centimeters distal to the wrist, across the dorsum of the hand, over the MCP joints and over the PIP joints, then adding the circumferential measurements together to determine the total. The formula used is the total visit at visit 1, subtracted from the total visit of the total of visit 2, which gives you X divided by the total visit that the amount that you got at total visit 2, which gives you Y, and then that gives you your percentage and change. You can see in the table that there was a downward trend in the edema over the first 4 days. His ROM was very limited, and he was unable to move his wrist at all. The wound, Mr. BM had 3 visits to theatre to ensure adequate drainage, as well as the incisions made on the dorsal side of the hand to prevent compartment syndrome. The initial incision was in the hypothenar eminence, volarly. You can see the corrugated drain that was left in the wound to allow for pus to drain from the wound. This was left for 3 days post-initial theatre visit. A volar incision was made on the thenar side, but minimal pus drained from this incision. The majority of pus was drained from the hypothenar incision. Mr. BM received daily wound inspections on ward rounds. Daily dressing changes were done at the OT department following the procedure I've described. Mr. BM's wound did not have any exudate on the 3rd OT visit, and I removed the drain that was inserted in theatre. At each dressing change, care was taken to keep the environment as sterile as possible by using sterile dressing packs that I collected from the ward. The wound continued to improve, and Mr. BM reported less pain. The problem that was identified for him is that he had a deep infection, he had edema, he had loss of active ROM, as well as some passive ROM of his MCP joints. His index finger and middle finger were more mobile than his ring and little finger. He had lots of stiffness, and he had loss of power and pinch grasps. I treated him using elevation, wound care, splinting, manual edema mobilization, and active exercises. After the patient was splinted in theatre on the 2nd debridement, which was on the Friday, he returned to the ward with instruction to elevate his hand. I went to hospital on Saturday to see the patient and assess his hand. Leaving that hand for a weekend on-call team with no therapy was not an option. The dressing was soaked and required changing. The patient had minimal active movement of the wrist and fingers. His wound was cleaned with pink soap and sterile water and dressed with Gelinet and gauze. The safe splint was remolded to ensure no pressure areas were forming and reapplied. His hand was elevated above shoulder height using a drip stand and a pillowcase to support and to elevate. It is my experience that patients cannot sleep comfortably with their upper limb suspended in the drip stand sling. Therefore, I fetched some extra blankets and discussed with the patient and nurses to please position his hand in elevation. As infection was present and the patient had open wounds that had exudate, I did not start pressure therapy, and at this time an MEM was not indicated. Serendipitously, our department received a donation of orthopedic supports that Monday, and this was the ideal support to position Mr. BM's upper limb and elevate it comfortably. Mr. BM was seen in theatre at the time of the second IND, and an intrinsic positive splint was made, supporting the wrist in neutral and the MCP joints in as much flexion as could be achieved, and the IP joints in extension. The splint was remolded twice in the course of his admission to accommodate more wrist extension and more MCP flexion. The splint was worn day and night in the first 4 days and removed for passive ROM exercises by the patient on the ward, and after that, only at night. I also made Mr. BM a static wrist extension splint to support his wrist in extension with dynamic attachments. The dynamic attachments allowed for active extension against resistance of the rubber bands. Leather slings placed over the patient's proximal phalanges and attached to the rubber bands were the force pulling the MCP joints into flexion. The patient was instructed to wear the wrist extension splint during the day and attempt to use his hand in activities. He was instructed to wear the dynamic finger slings for 1 hour at a time for a total of 4 hours during the day. In the table, you can see due to the infection, it was the change in edema percentage after MEM. Due to the infection that was present in the hand, I did not start MEM immediately. After the third IND, the wound did not have any exudate, and the doctor cleared the patient for MEM. The patient had a swollen lymph node in his left axilla, and I started with MEM clearance of the opposite limb. Pump point massage was not indicated as the patient had a swollen lymph node in his left axilla. Before starting MEM, I taught the patient clear exercises, which included deep breathing, trunk rotations, lateral trunk flexion, shoulder circles, shoulder ab and adduction, and elbow flexion and extension. The patient was able to do all these exercises through full ROM. I used light pressure and the U-shaped semicircular motions described in the literature to complete the MEM. From the 5th visit, all the therapy sessions started with the exercises, the clear exercises mentioned before, and then MEM. The table above tabulates the changes in circumferential edema measurements from the 5th to the final inpatient visit. With each visit, the edema was less, and the patient reported subjective improvement. As discussed previously, the wound checks were done daily and dressings changed as required. The dressings we had at this time were Gelinet and gauze, and that is what I used to dress the wound. Mr. BM was given a low-cost finger exerciser to use while he was on the ward. He was encouraged to do 10 repetitions with control and holding the contraction at the end of his available range for 2 counts. Activities that required Mr. BM to use a lateral prehension grasp was practiced in therapy. He did not have active flexion of his DIP joint of his thumb when he was admitted, and thus an adapted lateral prehension grasp was practiced for functional use at home. Pegs of varying resistance were used in his active exercises, as well as changing the goal of where he had to put the pegs. Mr. BM enjoyed the activities the most and was compliant with his finger exerciser in the ward, although the active ROM of his MCP joints increased minimally. Post-discharge, this is what he looked like at the first visit. The positive outcomes for this patient was the timeous effective treatment of the edema. Improved elevation on the ward in a comfortable device was a contributing factor, as well as the MEM. MEM is not just an effective way of managing edema, but also allows a trust relationship to be built. Mr. BM was very hesitant of his hand and arm being touched, but he tolerated the gentle application of MEM and trusted the treatment modality when he did not experience pain, and he was shown the results in his circumferential measurements. Another positive outcome of the treatment was the effective wound care and subsequent healing process. Mr. BM attended his first follow-up visit as an outpatient with his hand in a sling, however. He did not have his splints with him. He said he had been wearing them and that the static wrist splint with the dynamic attachment was helping the most, but in the same breath, told me that he had made an appointment at SASSA for a disability grant assessment. The next case I would like to discuss is Miss A.M. This lady suffered a human bite. She had presented at a local clinic and saw a PHC nurse, but was only treated with painkillers and was not given antibiotics or referred to hospital. She was referred to the hospital 4 days after the bite. She was admitted via theatre for an IND. She consented to VCT and was found to be immunocompromised. She did not get a stat dose antibiotics prior to theatre, and no MCNS was ordered. She was started post-debridement on IV antibiotics in the ward. She is originally from Mozambique, but lives in an informal settlement where she sells fish and vetcook to earn a living. This was assessed as a flexor tenosynovitis infection. Ms. AM was discussed with me when she was seen in OPD, and the doctor asked if I wanted to come to theatre to assess and see the hand. Under anesthetic, it can be a great time to do passive ROM. The doctor made a volar incision in theatre and extended it into her palm. This doctor did not feel comfortable cutting into zone 3 of the hand. The dorsal aspect of her index finger had a small opening, which was made bigger, and pus drained from both the volar and the dorsal aspects. I'm hoping that this video will play. You can see that the incision is made. The pus is pouring into that incision. This incision was then extended down to the tendon, and the tendon was exposed. This is day 1 post-IND. This lady was reviewed the next day in OT to assess the wound. She still had significant edema, including her forearm and wrist. She was in severe pain. When I exposed the wound, the tendon was visible and had a dusky appearance. I counseled the patient on the likelihood of amputation as the tendon was not viable and discussed with the ward doctor. She was consented in the ward for an amputation that afternoon. Her finger was amputated at the PIP joint level and a vac dressing was placed in theatre. Due to the vac dressing, she did not have her hand elevated over the weekend. I reviewed the patient day 3 post-amputation, and the findings are tabulated. She still had significant edema. The amputation that was done will need formalization to ensure that she can have secondary skin closure. The sepsis has to be managed prior to formalization. Treatment of Ms. AM, we did wound care, edema management using elevation and MEM, active exercises, and passive ROM, especially her MCP joints, which had become stiff. The picture on the left, probably your right, is day 3 post-amputation after the vac dressing had been removed. A hydrocolloid dressing was used after cleaning it with sterile water and pink soap. And you can see day 5, the middle picture, the macerated wound edges that was caused due to the hydrocolloid dressing. But you have got some improved granulation. The pic on the right is day 7 post-amputation. You see healthy granulating tissue with closure. The slough was removed from the wound bed prior to this photo being taken. All these dressings were done in the OT department with a sterile dressing pack using sterile water and pink soap. Dressings from day 5 post-op was a small layer of gelinate, absorbent fiber, and non-stick foam. This is day 10 post-amputation. The granulation tissue is evident. There's minimal slough or pus draining from the wound. The tendon is sticking out there, and that needs to be excised, and the bone needs to be nibbled so that we can have secondary skin closure and formalize that amputation. Her edema improved greatly, and she had improved active ROM. We used elevation and MEM to assist with managing the edema, and also active exercises. Light dressing was placed post cleaning of the wound to ensure that she can use her hand without a bulky dressing. She used active grasp and pinch. She was able to manage 10 cycles of 3 varying resistances, picking up 6 objects. She experienced fatigue and had to have breaks, but she was very happy with her progress. My take-home messages: early intervention is essential in a septic or a hand abscess. Get involved with wounds and wound care and use what you have. Thank you.
Thank you, Adri, for a great presentation. That was very helpful and insightful. Please, everyone, remember to post any questions you have in the chat box. Okay, so our next speaker is Niki Singh. So Niki graduated with her Bachelor of OT degree from the University of KwaZulu-Natal in 1999. She went on to complete her postgraduate diploma in hand rehabilitation in 2005. She worked for KwaZulu-Natal Provincial Health for 2 years before moving into the private sector. She currently runs a private hand therapy practice in Westville, KwaZulu-Natal. She is a past president of the South African Society of Hand Therapists. She's involved in a number of community projects and continues to provide mentorship and hand therapy leadership in her province. She will be talking to us about strategies for managing a patient with a stiff hand after a hand abscess. Thank you, Niki.
Hi, everybody. Thanks for the opportunity to speak. I'm going to be speaking about the management of the patient with a stiff hand after an abscess. So we're assuming that the wound has healed. You saw Adri's active therapy with the patient having the wound. So we are looking at the patient post-wound healing, but where the hand has become stiff. Okay, so let us look at the main objectives. We basically, from this talk, there should be an idea of how to treat the stiff hand according to the phases of tissue healing. And you should be able to understand the therapy modalities available to treat a stiff hand. Let us look at the stages of wound healing. The main phases, as discussed by Adri, is the inflammatory phase, the proliferation phase, and the remodeling phase. In these phases, we have different time frames of how the tissue will start to recover. And with this, we also have the appropriate management that must occur within these timeframes. So with the inflammatory phase, which is within the first few hours to first few days, we have to look at immobilization, resting the hand, use of splints, usually the static splints to maintain the optimal functional or resting position of the hand as desired, and looking at gentle mobilization. Bear in mind also that the wounds also would have some closing or some active wounds. So just be aware of this also, like when you're splinting. With the proliferation phase, is sort of the middle phase, we are now getting the laying of collagen fibers. And then with this, we're having to look at trying to apply light stress. So again, with your splinting, we're not going to dynamic, more static. Again, we're preserving the structures and the position, which is optimal to prevent a stiff hand, and controlling the edema. The last phase, where you have scar maturation, you have the organized patterns of the collagen fibers that have occurred. And we're looking now at trying to get the hand more mobile. And we are applying stress over a long period of time using strength, dexterity, and functional retraining. So ideally, this is what we're having to do when you have any hand that has a wound. So this is typically the stages that you would have to deal with. Now we're going to look at each phase. So if we look at the inflammatory phase, I've written a bit about the evaluation that you have to consider, because as you can establish from the previous presentation that it is a compound injuries where you're having muscle, bones, tissue, patients have pain, edema, and all other factors as well. So you have to be constantly evaluating as much as you would be treating. So use these type of things like your photographs, drawings. You can see how effective it is to help you to keep correct information about what's going on in the hand. Medical and surgical histories, look at the wound size, granulation, exudance, the fixators that may be present, edema, what is happening again with the circumferential readings, looking at your range of motion, and also the unaffected side, unaffected joints, because everything works in collaboration as a whole. Then you also want to look in your treatment is educating the patient. A lot of that, again, as Adri said, was educating the patient what they have to be aware of, because they're looking after the arm, especially if they're not admitted in hospital in the sort of later phases of the wound having healed. The next phase, the proliferation phase, again, be cognizant of what's happening with your pain, the wound, the edema, the range of motion. Sensation is an important one in order to try to become the prelude for activities of daily living. In your treatment, consider your scar management, desensitization, compression management, especially now in this phase where you don't have wounds or you got the tail end of the wound healing happening. So this can be applied with light dressings and compression garments over that. and then light prehension, where you're getting now your basic range of motion happening. It may be the beginning phase of the movement or the middle phase, because they don't have the full range at this stage. For the remodeling phase or the late phase, we're looking again at what is happening in the wound as a whole. Has it completely healed? What is happening again on the circumference of the wound in terms of the granulation of the tissue, how thick any scar tissue, keloid formation, any adherence of adjacent tissue, which needs to be looked at as you're working with your patient. Also remember that here we have also the effects of nerve, sensory losses, and we have to be aware of this and working on improving your sensation and your educating the hand to feel in order to allow it to mobilize better. Dynamic splints are widely used in this phase in order to get the hand to be active, especially when you're finding that the patient has partial movement. And by use of the dynamic splints, you're then getting a patient to be active in using the hand. So this, what we would also term functional splints, where a patient has partial movement, you support it with a dynamic component, then that allows the patient to be functional and to use their hand. And that then invariably improves your range of motion. So what I'm going to go through now is the complications. We basically have to realize that everything does not work ideally within the time phrases. As we discussed in these previous phases, we have specific time frames when things happen. But in the proper setting, we don't always get injuries timelessly. There may be other complications. So you have to be aware of these anomalies in order to improve what's happening in your hand. So consider the edema and the stiffness as the main component. You also have to think of your compartment syndromes, especially if it's the earlier phase. Look at pain. When you're considering pain, look at also with complications such as the complex regional pain syndrome, because while we may think it's expected that patients have pain with their complicated injuries, we also have to understand and pick up symptoms of the complex regional pain syndrome that could be occurring as well. Be aware of sensory loss, and here we have to re-educate and assist the patient in becoming resensitized to the different modalities, like your light touch, deep touch, rough, smooth, in order to make them have better control of gripping. Look at your scar contractures, because often this can affect the function of the hand, especially in bony areas, if the skin has become tight, so you're not getting correct glide of the tendons as well. Loss of function has many implications for people at work and for daily living. And also, it can also bring about financial issues if a person can't get back to work, if they were on temporary jobs and they lose their jobs. So these factors also will be cause patients to be sort of distracted when they're worried about these type of psychosocial issues. Consider if there's any infections or nail bed injuries which may be presenting as you're going along, because they sort of infiltrating different areas, or maybe it wasn't picked up sooner. Check what's happening with vascular changes. If patients have complications like Raynaud's phenomenon, see what's happening when they're having to use their hand or work in an environment which is cold, like in cold rooms. And then with this comes the complexity of multiple tissue. When you are seeing these type of abscess, they have global involvement with all tissue types. And this then causes damage and slow return of function in the hand. What we cannot also underestimate is the effect of cosmesis and personality types. If you think about all the pictures that we've been seeing and you will be seeing, we are sort of in affair with looking at these type of severe injuries. But what happens when it's your own hand, when person's body images are affected, people become self-conscious, don't use the hand, and it affects them even with the emotional aspects like depression. And again, personality types, because some people may not be able to sort of move past and become competent to rehabilitate themselves. There may be secondary gain that also comes across with different patients. So just keep this as a backdrop as we're speaking. We're going to go through different areas looking at the treatment, again, we're having this sort of picture of a patient that has a stiff hand. So typically, the stiff hand means somebody's hand going in sort of this pattern. They don't have your functional intrinsic plus or even the intrinsic minus function. But basically, it's this sort of stiff approach that we're looking at. The benefit of OT is that we have a wide array of modalities that we can look at. Again, the crux is to know that these things are available to you, but also at which phase and when to use it. So it's like pulling tricks out of a magic hat in order to help your patient. But the importance is to know how you're using it in order to gain the optimum outcomes for your patient's hand. So let us look at patient education. This becomes the fundamental aspect when working with the patients, because this gets them to commit to the hand rehabilitation, doing the exercises, because often I tell patients, you can't do your exercises once a day. It's little bits throughout the day in order to optimize the muscle memory and to get your hand to become less painful as you're exercising it. Consider what needs to be done for wound care as per the phase of healing and as per the medical doctor's recommendations. Look at your scar management, so where we do things like massaging, using sicker care, other types of compression agents in order to help the scar not to become keloid or to help it not to become adherent. Look at your sensory again, which is either desensitizing if there's nerve irritability, or sensory re-education in order to get the patient to be more tactile aware so that dexterity improves. Edema is going to be a big one we're going to go on about. There's different types of things to be done for this, and also looking at using your contrast baths with the heat and cold in order to help with the reduction of your edema. Active range of motion, so also passive range of motion. There are a whole host of exercises that can be used to help mobilize patients. And again, at different phases, we have isolated movements where you're just moving one joint at a time versus where you're doing a composite movement, for example, flexing the entire finger into a flexed fist. Then we also have different machines which you can use, like a continuous passive mobilization unit, and then also things like a tenodesis exercises or flexor tendon gliding exercises. Consider splints because they are a good agent to helping you get your desired range, especially once you worked on your hand. The patient's hand is pliable. You can have a splint, which then you serially adapt in order to get your full range of motion. And it also makes the patient's working time better in the hand because you already have a position that they can work from. And then obviously your purposeful activities, getting a patient to be as active as you can once they are able to get any type of movement or any type of grip, because this maximizes your tissue glide, your skin, tendons, muscles, bones. And the main consideration is muscle strengthening, that you don't overwork a muscle and then that there is fatigue. In terms of the considerations, when you're working with a stiff hand, you have to use the hand as much as possible, especially in the late phase when you're not concerned about having the open wounds and the having to be sterile, and it becomes limiting what you can do with the patient. So once you've got wound healing, it's important to get the hand to move, move, move. And this is where your innovation comes in as a therapist, to look at different ways and means of doing that. Again, remember that if you're trying to get a range, so let's say we want to get 90 degrees at the metacarpal, but the patient only has 30 degrees. So use that 30 degrees in functional activities. Think, what can my patient do with only 30 degrees of MPJ flexion, and get them to hold and use their hand for that functional activity. So it can be, for example, that you're using a bottle of water to hold and to drink that way with that limited range, but it's still affecting hand function out of that. Also look at your tendon gliding and length when you're doing your exercises. And when you've got prolonged edema, we're using different things, including taping, pressure garments, and splints to help with that. Again, we're preventing the stiff hand. We want to make sure that we reduce edema. So pressure garments have to sometimes be an ongoing modality that you use, that the patient uses daily at night, even if they're not using it in the day, in order to get your optimal outcomes with that, because it does help a lot for infiltration of tissue. And we want to use the exercise and range of motion functional abilities with splints as well. Be careful not to overload your healing tissue, especially sort of in the proliferation phase, because things are still coming right. And you want to also make sure that you avoid your intrinsic muscle tightness. And you want to gain mobility of the stiff hand by working on the exercises to focus on reducing the tissue adherence and your chronic edema. When we look at the stiff hands, the main issues that we have that you're working with traumatized tissue, there's multiple tissue involvement in terms of bone and muscle, and you may not get your optimal exercises in terms of that. So you have to make sure that you are exercising the hand as much as you can in order to prevent it from being immobilized over a long time, because often when you have bone and muscle, you're waiting for the bone to heal as a backdrop of when the tendons are healing, but then you're getting prolonged mobility of then 6 to 8 weeks. So you can't wait only at the 8th week to exercise. You have to do the little bits that happen in between also. So we're going to go through some pictures of the stiff hand because, again, these are happening at different phases of the tissue healing. Right, so you can see all closed wounds here, but this is now the whole dorsum of the hand. This is at the nail bed area. This is on the dorsum of the hand. And then again, look at that it's infiltrated to certain fingers that have the thickening or swelling. This is the amputation, a crash injury, multiple digits involved. And then you can see the stiffness of the joints now. So this looks more bony and hard compared to the other injuries that we had before. Here, this picture is showing that in a functional task that there is still residual stiffness of the hand. Again, this is sort of the like would be the proliferation phase where you're getting healing, but you can see that the tissue is still not optimized, and you can see the swelling, and again how globally it becomes all over. This is just again to remind you that we get multiple structures, and just by looking at this, even although there's no skin coverage, you can see how tight and stiff the bones are looking at this injured hand. So again, the open wounds here, but the healing well. So you can see again how the effect is on the IPJs, completely stiffened at the bone, not much mobility, but you do have some at the PIPs there. And that's showing you that there's some to exercise the hand. So those roughly are the pictures of what you will see, showing stiff hand. They've had wounds, some partially active with the wound, some completely healed. But the main thing is that you've got the ongoing stiffness, which is affecting bone as well. So with edema, the thing that you worry about is that we have different types of management. This is the medical management, where we're looking at assistance from your medical fraternity in terms of pharmacological medication, drainage, or surgery things. Also educating patients on diet and how to exercise globally to improve the edema, not just in the hand, and not wearing restrictive items of jewelry or clothing around that area. In terms of your modalities, again, there's a whole range from exercises to, and you can see the different types that I've listed above, as well as using different types of equipment like your TENS machines, CPMs, ultrasounds, even to help with reducing edema, if you're properly trained and know how to use those equipment. From a rehabilitative perspective, we're looking at compression wraps, massaging. There's different types in terms of your deep retrograde or even your MEMS. Splints, different types again, and we look at elevation. This type of intervention is ongoing in different phases, and obviously you would use more or less from this list depending on where the patient is at and according to what's available to you. And then we're gonna, so just basically with the MEMS, this is your manual edema mobilization, which is a light rubbing, usually working from proximal to distal rather than distal to proximal with your retrograde massage. And usually you have to be trained in this massaging technique. If we look at splints, once again, the benefit of being in OT especially is that you have a whole range of splints that you can make and things that you can devise even to help with getting a range of motion. Adri showed us the pictures of what she did in that early phase with getting the static progressive flexion of the joints. So these are showing your individual finger dynamic splints. So this works quite nicely in your late phase, where you have a stiffened joint and you're trying to get functional ability, and especially when it's isolated in specific joints. These is looking at the casting. So we'll talk a little bit on the casting of the hand to optimize your range of motion. The gutter splint, a simple splint like this, just to prevent the joint from getting stiff, is very advisable. And obviously you would advise the patient when and how to use that. Blocking motion splints. Okay, so with the casting motion splint, this is to mobilize your stiff hand. This is using plaster of Paris, and we're trying to isolate joints in order to get the joint that is not isolated to mobilize better. So in this picture, as you can see, if you're thinking of the typical stiffened hand like this, we want to get the metacarpals into flexion. So this is what they've done here. And they've left the IPJs free, so that now the patient is forced to mobilize the IPJs within that splint to get you the optimal ranges that you want. Okay, and again, just in this slide, we're just showing you that you're moving from your stiff hand into your intrinsic plus position, intrinsic minus position in order to get a functional range here. So again, just be aware that we have your intrinsic plus position, which is this, and then you have your intrinsic minus position. And we also want to use your tenodesis effect in order to get your hand out of the stiffened hand position. This is just briefly telling about the casting procedure in order to give an idea of how to do this serially, and it's got some time frames of how you would remove the cast and put a new one. Typically with the casting, you want it to be on continuously, so you're not doing it with thermoplastic, but you're doing it with a pop in order to make sure the patient adheres to that, and then you get low-grade stretching of the joint. So ultimately, the takeaway message from my side would be move, 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 move the hand. As soon as you got even a slight improvement in the range of motion of whichever affected joint that the hand is affected in. So we have passive and active exercises. So often, if you're not sure how to do passive exercise, although we think it's the non-invasive one, our forces can be too forceful for a joint that's healing. So you may have to actually go with active mobilization, functional activities and games in order to get the movement of the hand better. And in that way, you're also encouraging less pain cycles. So be aware of the passive, because we have good intention of getting that range of motion, but it can be detrimental to the tissue that's not ready for force. So that's just a repetition of making sure that you balance your hand exercises with resting. For me, my favorite, and I think the go-to for myself, is this tenodesis effect, because when you simultaneously dropping the wrist, you're getting your fingers to extend. And when you simultaneously going into extension of the wrist, you're getting your fingers to flex and thumb. So that becomes a very nice, non-invasive way in order to get the desired stretch and excursion of the muscles. So often we forget about sensory because we only think peripheral nerve, or we think of brachial plexus nerve damage and you think only of nerve. But just remember, you have to look at desensitization or resensitization, and the feedback, the appropriate feedback in order to help a patient grip. So you may have to do some isometric strengthening in order to get the proprioceptive feedback. So this is an important area, and we can do this using games, using weight-bearing exercises, in order to achieve this in your hand. Looking at the skin, don't forget that the skin is an important organ, and you can see with the wounds and the pictures we've seen earlier that if you don't have skin cover, then you're not going to have protection of your underlying tissue. And when it is hard and taut, you're not going to have gliding. It's going to affect and adhere to your tendons. So you have to make sure that you are aware of the skin quality and work on your massaging, on pressure garments and different types of modalities to get the skin to become active again. Beware of flexor tendon tightness. We spoke about the intrinsic plus positions. So also look at different ways to optimize your movements so that you don't get shortening. The last aspect is heat therapy and massages. Often, traditionally, this was a physiotherapy modality, but remember, muscle is elastic, so you don't want to have the pliability of it. So using heat packs, using wax therapy, massages, these help very nicely to create the glide of the tissue in order to optimize the movement that you want to achieve. And it also helps with sort of pain management as well. So as you can see, there's a wide array of modalities available to the hand therapist to help with assisting with your mobilization of the hand. And I always say that you can be as innovative as you want and do lots to help your patient's hand. I thank you for your attention, and I hand you over to our coordinators. Thank you.
Thank you, Niki. That was a great presentation and very helpful. Lots of useful techniques to use. Yes, we have had quite a few questions in the chat box, so we'll post some of them to our presenters as well, so they can have an opportunity to answer for the recording also, and just to give some more ideas. Okay, so there have been quite a few questions about the role of OT in wound management. So Adri, what do you think OT should be doing, and what further training is available to them, and how can we collaborate with wound care sisters to get the best results for our patients?
Yeah, I think wounds and wound care does fall within the scope of OT, because we do not see hand pathologies without wounds. Even the basic flexor tendon repair or anything is going to have a wound at the end of the day. And where I work, my context is rural and district. So I have one private wound care sister that is practicing in Manguzi, and how I've gone about working with them is when a patient is ready for discharge and can afford a wound care sister to come to their home, that wound care sister will come to the hospital, look at what dressings can be provided to the patient on a home-based care basis, and then see how many times the wound care sister can go and visit them. So it's really a collaborative practice. I find that the nurses in the wards are always very grateful for further training and discussion about wounds. I've reached out to a surgeon called Dr. Niki Singh, who's doing burns, and she flew up here and came and did a burns ward round where we discussed how we manage burn wounds, and she came up with her OT, and it was an MDT approach. So I think using, you are going to do what you can with what you have, but for me, you can always learn more about wounds. It's available out there. And I think it is just whether or not, just working in collaboration with wound care sisters and with the nurses in your wards as well. I think post-grad training is beneficial. Any training on managing wounds, I think, is always really a great thing to do, because as that one question said, is we don't get taught it a lot. We don't get taught specific wound care at undergrad level, but you get taught about wound healing and wound phases. And I mean, you need to know all about the wounds, but no one's telling you what to put on the wound. So I find that a bit strange. So maybe that's the gap that we need to address at undergrad level. I don't know.
I just want to quickly add to that. I think even for myself, a wound care was something that we weren't taught. Even when I did the diploma, I thought I'll know it all after that. So you have to make sure that you are speaking to your team. The nurses speak to the doctor, the surgeon. So you have to phone them to ask them what is the preferred dressing and protocols if they haven't already said it to the ward or to the nurses or to yourself. So you're going to have to ask, because there's different things from dry dressings to wet dressings, according to what type of abscess there is, or in terms of infection. You're going to have different things for that. So I think you have to ask. Secondly, in terms of pressure garments, most of the time you saw the wound pictures that Adri showed, that the wound had to be open. You leave it open because you want the exudants to come out. So pressure garments, normally we do it in the very late phase. So we're looking again the proliferation and the later phases, because the wound has got closure. The reason we also want a use of the pressure garment is to help the edema to flow. If you're putting that early, it's going to cause the sepsis to flow. because of the different compartments. You have your extensor compartments 1 to 7 going across. So often we don't want to put compression early days because we don't want the wound to spread. We want to keep it open. So then you're going to have to do your pressure garments at a later phase. Thanks.
Thank you for that. And then there have been quite a few questions about the technique of using running water to clean a wound. So what sort of water do you use? Do you just use clean water, or do you use saline? And what is the reasoning for using that instead of the iodine solution that I think a lot of places still use even these days?
Yeah, I did talk about it. So for me, the reason why I like to use running water is if you think about a basin and now you filling it with water and whatever solution you're using. I don't use iodine solution because we don't have it usually. We're out of stock. And it is something that is used in theatre for cleaning skin in cesareans. So they are quite sticky about their iodine. And there's nothing wrong with pink soap. It's got all the right things in to clean it. And that's why I use it, because it's more readily available, and it's available at clinics as well as hospital. You can, you can even decant it and give some to your patients if you want, where it's a different story with iodine. The reason why I don't like using a bath is because you are putting a septic hand into a bath and then asking the patient to move it, and then the exudate and the pus is draining into the bath, and that's how you clean it. But it just becomes like the septic soup in my, I don't know, it just, for me, it goes against what I'm trying to do. So I use clean water. Clean water is either sterile water if your hospital's got it. Otherwise, I boil water and cool it down so that it's clean, and then add some Milton solution so I know that it's sterile. And then I get a metal basin or a kidney dish or a sieve that is sterile, and put the hand over it and pour it and wash it and pour it so that and put that in the bin or in the drain or wherever, and continue with that until I feel that it's clean. I did go on a wound care course, and I'll never forget what Sister Liz told us there, and I loved it. It stuck with me always. The only solution to pollution is dilution. So you cannot get the sepsis out if you keep adding to it, like in that bath. That's why I just prefer to wash it out until, it's running clean or blood is coming.
Niki, a question for you. There's been a few questions for Niki, there's been a few questions about managing a very late presentation of a stiff hand. When do you decide that there's still something that can be done, or when is it too late, and how do you manage something that's like a very, very old injury?
Okay, that was basically the problem that you have in our current context. So you have to look at where is the patient at in that phase of time. So often the wound at that stage should be well healed, but you may find that the tissue around that is damaged and tight and cause contractures either of the skin, the tissue, or the actual joint itself. So you would have to actually then focus on range of motion. What is the range of motions that are limited? Which joints? And that is because of your function. So you have to go back to your patient's lifestyle. Is this my nurse? Is it a housewife? Is it a teacher? What is the need for her hand function? Does she need it more for writing versus for eating versus for whatever? So you have to actually then look at the lifestyle of the person, what they are doing, and work on getting that stiff hand to fit in for their lifestyle skills. And that's why I'm saying start with a range of motion. So if it's somebody that's needing to be doing less non-prehension things, then you're having to work on the splints that will aid that function as well, and the activities which would work that way. Often when it's a stiff hand, I like the tenodesis. That gives it a good starting point to get the hand to get mobilizing. And even your tendon gliding exercises, we learned that one. So that actually becomes a nice starting point to get the glide, because it's sort of pre-programmed in our hand and helps the tissue glide that way. I hope that answers the question.
Thank you very much. And then just 2 more questions. So Adri, there's been a few questions about how soon can you start active movements? Are there any precautions for starting active or passive movements after a hand abscess, after the incision and drainage? At what day about would you consider starting active versus passive movements?
So usually I find that within a hand sepsis, you have a lot of edema and swelling, and there's a lot of pain. So the patient doesn't want to move. And that is obviously where the OT role is important, because you're coming in and you are maintaining ROM, splinting in a position that is going to maintain the soft tissue at length and the tendons at length, or the ligaments at length, sorry. So I don't think there's a hard and fast yes or no, but you are going to respect the patient's pain. You are going to look at what, obviously, if the hand is stiff like this, you're really going to try and splint it. I often go to theatre and ask to do that in theatre when the patient is under anesthetic, so that we can do that. I can also use a dorsal blocking splint with POP. I find that very helpful. I saw there was a question about SIMS. I think SIMS is a great modality to use in a stiff hand and works really well. And also you can do it at a very late stage. So I think the earlier to move, the better. But it's never too late to try something like SIMS. I also saw there was a question about overgranulating. If a wound is overgranulating, that means that that wound bed has obviously got some bacteria in it, and it's not going to stop. It's not going to magically go away. So you have to debride that wound bed and get it down to base, so that you can get secondary closure of the skin over the wound. That can be done using silver nitrate sticks, which is available. Otherwise, you have to ask your surgeon to take you to theatre and just scrape that hypergranulation off. But in my hospital, in my setting, we use silver nitrate quite a lot.
And then Niki, a last question for you. Do you see a role for mirror therapy in treating stiff hands from hand abscesses?
Yeah, so again, it's once the wound is healed, we're working at where now you've got stiffness of the joints. So the mirror therapy definitely helps. I've used it extensively with strokes initially, and now I use it for orthopedic conditions, because what happens, it helps with minimizing pain. Because now you're not forcing the passive ranges, you're getting the patient to actively exercises with the mirror, and you're getting the biofeedback. Again, we also think about biofeedback only with your neurological cases, but remember the orthopedic cases is also very important. They have shown more and more neuroplasticity even with your orthopedic conditions. Just by stroking the skin, your brain is already being alerted to you being touching. So it's creating motor pathway to say, what must we do with this? Must I move the finger? Must I respond and copy the stroking? So that is already creating pathways for movement. So that's how mirror therapy actually fits into the whole domain of getting that hand to mobilize, because you're working on pathways and it's less painful than passive exercises, for example.
Thank you.
Thanks.
Okay, so I think that's all we have time for tonight. Hopefully we've gotten to most of your questions, but if you still have any questions, then you can send us an email or reach out to us on social media so that we can help you. So thank you for joining our webinar tonight, and thank you to Niki and Adri for your great presentations. Our next open hand webinar will be on the 6th of August, and the topic will be rehabilitation of distal radius fractures. We will be opening registrations for the webinar soon. If you want to keep up to date on upcoming webinars, then you can follow us on social media. You can also sign up to our mailing list by sending an email to info@openhandtherapy.org with your name and surname. So spread the word, and we hope to see you all then. I'll leave the slide up a little bit in case you need to get the details, but thank you for joining us. You're welcome to leave when you're ready.